Hello and welcome to Acupuncture Professional. Today's webinar is talking about safely treating conditions in the first trimester of pregnancy, presented by Sarah Budd. By way of very brief introductions, my name is Kath Berry, and with me I have Luke Rickards, who's broadcasting from Sydney, Australia.
Hello everyone, thank you for joining us again for today's webinar. It's great to have you all on the line.
It's now with great pleasure I introduce to you our very special guest speaker, Sarah Budd. Sarah is a nurse, midwife and trained acupuncturist. Sarah set up an acupuncture service in Plymouth Maternity Unit in 1988 after completing a degree in complementary health studies at Exeter University in the UK. In 1991, Sarah was awarded the prestigious Churchill Fellowship Award to study acupuncture anaesthesia in China. Sarah was appointed the UK's first full-time acupuncturist midwife funded by the Public National Health Service in Plymouth. To date, over 8,000 pregnant women have been treated with acupuncture on the NHS in Plymouth, and the service was joint winner of the Prince of Wales Foundation for Integrated Health Award in 2001. Sarah has contributed to textbooks and journals and continues to work in clinical practice and to teach in acupuncture colleges and universities. It's with great pleasure I introduce to you Sarah Budd.
Thank you, Catherine, for your warm welcome. Okay, so today's topic is safely treating conditions in the first trimester of pregnancy. This is a thing I find very interesting, talking to other practitioners, but also there is a lot of worry that goes around about using acupuncture at this stage of pregnancy. So today we're going to run through some of the most common things seen in the clinic, and I hope to reassure you and share my experience about treating these conditions safely. So Catherine's already given a very nice introduction, thank you. And these are my two colleagues you can see here on the right, Sharon and Kim, who run the service with me. We now only work 1 day a week each, seeing antenatal patients in an outpatient setting. We do sometimes see inpatients on the wards, but most of our work is antenatal outpatients. You can see where we are there down in the southwest of England, and that's the front door of our maternity unit. So we each see an average of about 10 to 12 patients per day on this service. Sharon and Kim both work on a Friday, and I'm on my own on a Tuesday, so we're not all in at the same time. Our referrals come from GPs, community midwives, hospital midwives, and hospital doctors and physios, and patients can also self-refer, and we do get that. We've been going such a long time now. We do get ladies coming back to us in subsequent pregnancies who tend to have the same problem and choose acupuncture as their form of treatment again. The majority of the cases we see are sickness and hyperemesis alongside backache and pelvic pain. Now, for today's topic, I'm actually going to be talking about sickness and hyperemesis a fair bit because I expect you already know in your practices this is a very common problem in early pregnancy. Although having said that, I have seen pelvic pain in the first trimester, which is pretty unusual, but we're not going to go there today because it's usually something that happens later in pregnancy. Could we maybe just have a show of hands of people who are treating pregnancy conditions in their clinic? Thank you.
So if you just take a moment to please raise your hands using that hand arrow up icon. That's it, we've got lots of hands coming up now. We'll just leave it another minute or so just to give everybody an opportunity to cast their vote. So again, please raise your hands if you are currently seeing pregnant women in your acupuncture practice.
So Sarah, it looks like we have 65% of attendees tonight who are currently using acupuncture in the first trimester of pregnancy at the moment. So a very, very enthusiastic and experienced bunch.
Okay, that's great. Thank you, Luke. Thank you, everybody. That's useful for me to know. So there's a few people there who aren't currently seeing pregnant women, so I can take that into account. And maybe for those of you who are, maybe ask you if you don't mind to perhaps share some of your experience later on, so that would be useful. Okay, so
Sarah, I'd
today...
just like to chip in at this moment as well. So I just wanted to chip in at this moment when I was studying acupuncture a number of years ago in Sydney, Australia, we were cautioned against treating pregnant women for the first 5 years of clinical practice. So I'm of the generation of practitioners that was terrified to go near a pregnant woman for fear of possibly doing something wrong. So I thought to contribute that, perhaps representing some of those people that might be a little bit cautious about treating pregnant women.
Yeah, thank you, Kath. Actually, that's really helpful because I do want to mention, of course, I don't know where our audience is coming from, but in the UK, the training in obstetric acupuncture is terribly varied. Although we have an acupuncture accreditation board for our acupuncture training courses in this country, it doesn't seem to extend to the sort of more specialist areas. And I know from teaching in some of the different colleges and universities here that undergraduate obstetric training is terribly variable. Some courses will spend a whole day on it, and others just a couple of hours. And of course, for practitioners who are trained not in the TCM style, perhaps through the British Medical Acupuncture Society, they're actually told not to treat pregnant women. And so are the physiotherapists. And so if they want to treat pregnancy conditions, they have to do further postgrad training. So it's a very mixed bag of knowledge that practitioners are starting up with. So I hope I've taken that into account today. Obviously, this is aimed at CPD postgrad, so we'll have to see how much we cover from the physiology point of view, etc. Okay, I'll move on. So the things we're going to cover today are physiological changes in pregnancy, and that's really just to build a picture of the pregnant woman at this early stage, because so much changes. It gives us a good kind of explanation for why on earth they sometimes can become so poorly in the early weeks of pregnancy. And so I'd like to also touch with that in view to things that you may not have thought about that you may need to change in your treatment room. Of course, we have to discuss the forbidden points during pregnancy, particularly since this webinar is about safely treating conditions in pregnancy. As I've said, I'm going to touch quite a bit on nausea and vomiting, including hyperemesis gravidarum. We'll talk a bit about headaches, constipation, fatigue, bleeding, abdominal pain. Ectopic pregnancy, I feel, is an important issue to cover. Threatened miscarriage and urinary symptoms and some red flags. Okay, so that's our outline for the next couple of hours. So these physiological changes in pregnancy, you can see that lovely picture there of, wow, just look how much space that baby's occupying. Not in the first trimester, I hasten to add, but just look at the changes and the weight that woman has to carry around, and all the huge changes going on. Her blood volume would have increased by 30% in the very early weeks of pregnancy, which people may not be aware of. The changes, hormonal changes, have effects on the respiratory system. The lining of the nose is affected, so you may see women presenting with rhinitis type symptoms. Women can become quite breathless, and if you look at that picture, it's not surprising if you're carrying that around. But even in the first trimester, so we're talking of course up to the first 12 weeks of pregnancy or so, women can become breathless, and it's just due to all these huge changes in circulation and hormonal changes of linings of tubes, basically. The musculoskeletal system obviously has to really adapt to the growing baby. So there's an increase in the synovial fluid in the joints, and there's also a hormonal effect on the density of connective tissue. And those of you who are treating pregnant women will be well aware of issues such as pelvic pain, and backache, and particularly the pelvic pain. We know there's a hormone called relaxin that loosens the joints at the symphysis pubis and sacroiliac joints. And this can happen quite early on. So you may well see musculoskeletal conditions cropping up. And they certainly do later on. It's a very common problem. As far as the gastrointestinal changes concerned, you will be seeing possibly heartburn and certainly constipation in the first few weeks. Progesterone relaxes smooth muscle in the whole gut from the mouth all the way down to the other end. And this change in the peristaltic activity can affect issues such as constipation, and also the gastric sphincter at the top of the stomach becomes a bit slacker and can result in heartburn. And again, this can occur quite early on in pregnancy. There's also skin changes. I can't actually see it very well on this lady, but some women have a very strong linear nigra going down from their tummy button down to their pubic bone, as well as other changes on the skin. And the renal system is also undergoing massive changes during early pregnancy. And we'll talk a bit more about constipation and urinary symptoms and why they're relevant later on in the presentation. So from the TCM perspective, there's a huge change. We say that there's an accumulation of blood and body fluids in the pelvis. And of course, because she's not menstruating anymore, losing blood monthly, there is more blood available. This blood is gradually transformed into milk and transfers from the lower jowl to the upper jowl. And this can cause an increase in heat in the woman, and also is said to be possibly responsible for the feeling of morning sickness, as there's this feeling of rising up from the lower jowl to the upper jowl. So any pre-existing tendencies that your patient has will influence her response in early pregnancy. So building a picture, you may have this woman in front of you with a set of symptoms and wondering why on earth she's having such a struggle. I think it's good to talk to her about how she was before she got pregnant. Was it a planned pregnancy? Is it a shock that she's pregnant? There may be a lot of other emotional issues about getting pregnant, possibly a lot of stress. Considerations such as financial issues. Has she just started a job? She's going to have to tell her boss that she's pregnant. And if she's being sick, that could be a real problem because she's trying desperately to hide the fact until she's further on in the pregnancy. So all of these things are relevant when you've got your patient sitting there in front of you to bear in mind. Was she overweight before? Has she got a stomach and spleen deficiency? And if so, how is this affecting her energy and her general coping with all these changes, particularly in the gastrointestinal tract? So when we're seeing these ladies early on in pregnancy, you need to think about how you're going to have your treatment run. When I first started treating sickness as an antenatal problem, going back quite a few years now to the late 80s, 1980s, I was taught as a midwife that morning sickness is a minor disorder of pregnancy, and it was pretty much left at that. And then I started having women walking into my acupuncture clinic carrying a bucket, a bowl, a box of tissues, just looking dreadful. And I was really quite alarmed. I had no idea that these women could be so ill. So if you're not used to treating pregnant women, and you know you've got somebody coming to you for sickness, possibly with hyperemesis, then you do need to think about things like having a bowl handy, having a box of tissues and a glass of water. They will be dehydrated. They won't want to drink the water, but if you can persuade them even to have one small sip, then that's a good idea. But I'm afraid they may suddenly throw up, and you want to be prepared for that. Positioning, again, just be aware that even in these early stages, she may be feeling pretty rough and fairly vulnerable, and so make sure that she's in a really comfortable position for your treatments. At this stage, you're fairly safe to lie women pretty flat. We do take care later on in the pregnancy never to lie a woman on her back flat because of postural hypotension. The weight of the baby can put a lot of pressure on the inferior vena cava, and her blood pressure can drop quite considerably. At this stage of pregnancy we're discussing today, it doesn't really matter, and you're probably going to be using some tummy points, so you don't really want her sitting bolt upright. Ventilation is important. My private clinic is in my house, and so pregnant women being very sensitive to smells, if they've got sickness, you don't really want to be having strong cooking smells wafting up the staircase, or any other unpleasant smells for that matter. You may want to consider having a gentle waft of some aromatherapy oils in your room, but again, you do need to make sure that they're safe to use in pregnancy. Something like peppermint can be quite nice. It's very refreshing and cooling. We say that it's better not to leave the patient alone. If they're not used to having acupuncture and they're coming to you for the first time already pregnant, which of course is what we have in Plymouth in our NHS clinic, they may be very anxious. When you're treating patients on the NHS, the National Health System in England, they don't have to pay for their treatment, so they're almost sent to see you, as opposed to coming privately and having made a choice, perhaps having done some reading and some research. So some of our patients arrive needle phobic, terrified, and again, with the needles in, they may be prone to fainting. So just keep a really good eye on them. Focus on the problem when treating pregnant women. They really want you to just sort out the problem that's in front of you today, not the sore knee that they had 15 years ago when they fell off a bike. So keep the treatment really structured, and as you sort out their pregnancy problem, you may then have a patient for life, of course. And then you can treat all their other bits and bobs. We say to use few needles. Acupuncture in the first trimester is safe, but it's better to not use too many needles. You don't want to scatter their chi. You want to really focus on what you're treating. And with that in mind, think about your needle technique. In my experience, pregnant women don't need strong needle technique. They really just need the chi and blood and any other issues gently sending in the better direction that they need. And so gentle technique. If you have a woman with a really strong excess headache, by all means use reducing technique, but keep it fairly light. You're not treating an 18-stone rugby player who's got a sore back and needs a strong reducing technique. So keep it gentle. You can use tonification, you can use even method, but just really a light touch. And there's something wonderful about the response with acupuncture in pregnancy. And I find that they just need a gentle needle technique, and they will do extremely well. Frequency of treatments may be slightly different when treating pregnant women. Ideally, with something like hyperemesis, you really want to see them more than once a week. Unfortunately, I can only see my patients once a week in Plymouth, but if I'm treating hyperemesis in my home, I try and see them 3 times a week, or at least twice. And you may have to do some kind of deal about payments, that's up to you. But if you can see them more frequently, you'll get them better quicker. And again, they'll be eternally grateful, and it's very satisfying. Before I had my own family, I used to be doing acupuncture full-time on the NHS, and I was able to see patients 3 times a week, and I found that by the 3rd treatment they were better. So they started on Monday, I saw them on Wednesday and Friday, and they were better for the weekend. Fantastic. So if that's feasible for your practice, then I do recommend it. So that's a matter of what is ideal and what is actually practical. So a quick red flag coming up here. There are very good reasons, which we will talk about, why it's important if somebody comes into your practice already ill that they get referred to their midwife or GP. Again, I don't know what your situations are in your different countries, but here a midwife is allocated to the woman in the early stages of pregnancy. Although sickness can start at 5 or 6 weeks, so she may not have actually met a midwife, but she can certainly get referred to a GP, and that will spin off a referral to the midwife. It varies as to when the midwife will meet the woman, but they usually get involved something like about 8 weeks, but that is variable. But anyway, she does need some kind of medical referral. There is a system here, and I don't know, again, if it's the same where you are, but there are a group of antenatal early pregnancy units, or day assessment wards, they're sometimes called. They're located in maternity units, and they're there to take referrals early in the pregnancy, and they have midwives who are trained in scanning to check out things like vaginal bleeding and abdominal pain. And they will be pleased to take a referral. If you're really worried about a woman and you can't get hold of a midwife or GP, just have a look and see if there's an early pregnancy unit. Might have some information on that later, which I can dig out if anybody wants it. Ask me later. Okay, so those are things just to be aware of, and we'll be covering this as we talk about the different conditions. Okay, so I hope you're all right. We're going to talk now about the forbidden points during pregnancy. This is an interesting issue. There's a lot of conflicting advice about which points are safe to use in pregnancy. The main concern being miscarriage, or later in pregnancy, stimulation of contractions at an inappropriate time. But generally, we find that there is an agreement about this list. Even in the ancient texts, going back to 241 AD, 1220 AD, avoid lower abdominal points unless specific indications, and various other mentions in the texts. So I'll just run through these quickly. I guess you're already aware of them, but colon 4 and spleen 6 are used for induction of labour. They do have a stimulating effect on the uterus, and we do say avoid until 40 weeks, and not at all if a woman comes for treatment and you're not sure whether she's pregnant. So just to check that out, if somebody's coming to see you, a young woman, that there is a possibility she's pregnant before you use those points. And we say that spleen 6 alone from 37 weeks is fine, as it's used to prepare the cervix for labour. Gallbladder 21, Jianjing, this has a strong downward effect, and it's used for retained placenta, so we can see how it can affect the uterus in terms of making it contract. Spleen 1, Yinbai, is used for stasis of blood in the uterus, so we feel it's an important point to avoid, not to move blood in the uterus in early pregnancy, or even later on. Bladder 67, Jiyin, this stimulates contractions, can be used to help the position of the baby at term, if it's a posterior position, or with Moxa only from 34 weeks to turn the baby in breech position. But it does have a strong effect on the uterus and contractions, so it should be avoided in early pregnancy. Bladder 60, Kunlun, moves blood in painful periods with stasis, and again, for that reason, should be avoided in pregnancy. Ren 3 to Ren 6, the lower abdominal points, avoid during pregnancy, but the higher abdominal points can be used according to the gestation. So you're really thinking about points like Ren 12, Ren 14, those sort of points, which are fine until the growing baby gets up that high. So the uterus reaches 28, the umbilicus roughly, of course it's very individual, about 28 weeks. So you're usually fine to use those points above that. Bladder 31 and 32 and those other lower sacral, sacroiliac, lumbar sacral points, these are used for induction of labour and therefore not used before 40 weeks. So I'll leave that list there for now, and I'm happy to come back to that a bit later on if you would like. We talk about caution for certain points, and so just use your judgment about points such as liver 3, Tai Chong in early pregnancy, in women with a poor obstetric history. So if they've had recurrent miscarriages or bleeding in the pregnancy, liver 3 moves qi quite strongly. So just to be aware of that if you're worried about her obstetric history. I've already said not to use strong needle stimulation unless it's the end of the pregnancy for induction of labour. Beware of positioning and anxiety. Points like kidney 1, I find that has such a strong downward action. I tend to, even in non-pregnant people, quite often use acupressure out of preference. But just, you know, thinking about if a woman is kind of bits kind of scattered and you're thinking, oh, kidney 1 will kind of bring her back down to earth, just be aware that it may just be way too strong in pregnancy. And pregnancy is generally a hot condition. This little baby in their tummies is causing a lot of heat. And so most pregnant women will be, you know, opening windows and not wearing much except a t-shirt, etc. So just be careful about using things like Moxa. We can use it for breech babies quite safely, and it can be used for backache with cold later on in the pregnancy, but I wouldn't use it in the first trimester. There's a debate about this issue, and there were 3 articles published in Acupuncture in Medicine. Deborah Betts, my friend and colleague in New Zealand, and I both contributed to this debate, and our article is mentioned there on your screen. There's a link there to it. If you go to that link, you'll be able to see the abstract. Sorry, no, I thought we might have had it there. But you will then be able to link to the 2 other articles which contributed to the debate. One is by Mike Cummings and the other one is De Silva. And you can, it's quite interesting reading actually, because they come from a different acupuncture background, and from memory, I think that they're kind of saying that there's no such thing as forbidden points. So I do encourage you to see if you can have a look at them. It makes quite interesting reading. Deborah and I have argued that there is a lot of writing in the ancient texts relating to these forbidden points. And there's some interesting ideas in our article about what happens physiologically in the difference between the first 10 to 12 weeks of pregnancy and the final 4 weeks, and how women can be more susceptible to acupuncture treatments at this time, particularly those which increase blood flow to the uterus and influence the hormonal responses and stimulate contractions. We know from infertility work that acupuncture can have a strong effect on implantation rates, etc. So we feel that this is relevant, and so you can find out more about that. Some research has been done looking at adverse events of acupuncture in pregnancy, including sickness, morning sickness particularly, and safety of TCM acupuncture in pregnancy, and shows low adverse events. So when used appropriately. And also, of course, you can always use another point. I've always found that when I've been doing obstetric acupuncture, I find myself wanting to use a certain point. Think, oh no, I can't use that. I'll use another one instead. There's usually a complementary point, a point that will do a similar action, and so choose that instead. Contractions can cause a lot of anxiety if they're too early in the pregnancy. So we really don't want to be causing, certainly don't want to be causing any harm. And we have to bear in mind all the time that we're treating two patients, the mother and the baby. And for me, the safety of the pregnancy is absolutely paramount. Okay, so I'm sorry I've put up a slide too early there. Moving on to nausea and vomiting in pregnancy. How many people, if we could have a show of hands please, are treating morning sickness, and actually how many people are treating hyperemesis or have treatment experience of treating hyperemesis? Could we just have a little look at that?
So we'll do a show of hands firstly for how many people are seeing morning sickness. So this is sort of a mild feeling of unwellness in the early stages of pregnancy. And following that, we'll see how many people have actually come across hyperemesis. So again, taking a moment to raise your hand using the hand arrow if you're seeing nausea and vomiting in the early stages of pregnancy.
And we'll just give you another few seconds there. So we've got half the hands raised, 52%, Sarah.
Okay, thank you.
And so we're just going to lower all those hands then. And can you raise your hands again if you've come across hyperemesis gravidarum? Another 3 or 4 seconds. And thank you, everyone. 24%, so around a quarter of the audience tonight is familiar with that.
Right, that's fantastic. Thank you very much. Well, nausea and vomiting occurs in approximately 50% of all pregnancies, so it's quite a high number. The worst stage is usually around 7 to 12 weeks gestation, but this is by no means fixed. And you quite often get women coming into the clinic a bit fed up because they're 16 weeks pregnant, still being sick, and everyone's told them it should have gone at 12 weeks, which isn't very helpful. It can range from mild nausea to hyperemesis gravidarum, which we will go into in more detail in a minute. Why does it happen? Well, as far as we know, hormone levels, progesterone, estrogen, and HCG, human chorionic gonadotrophin, all influence the gut, and the brainstem response to the hormones can contribute to nausea. And we also know that fatigue, stress, and emotional factors do play a part. So I've already said, it's a huge thing becoming pregnant. Usually a joy, hopefully, but not necessarily. So it's really going to have an effect on this condition. And a little red flag there, danger of dehydration leading to electrolyte imbalance and ketosis, and hospital admission for intravenous infusion. Just pop that in there. We will be going over that again, but in the old days, women could have died from hyperemesis because they wouldn't have had intravenous infusions to be rehydrated. So that's how serious it can be. So let's talk about this horrible condition first of all. It occurs in 2 in about 1,000 pregnancies have real hyperemesis gravidarum. They have continuous nausea and vomiting with increasing dehydration, and they develop acidoketosis, which can be quite dangerous. You can look at their urine volume and concentration, and these women will not be able to drink. If they drink, they throw up, and so they're getting very little fluids, and this is the main problem. Most people can go without eating for a while, but not without fluids, and it's this dehydration that is the real issue here. So I always ask them how much they're peeing and what colour is their urine. This is a good indication in your clinic of how dehydrated they might be, and if they've got true hyperemesis, you'll probably find that they're hardly peeing at all and that their urine is very dark yellow. It can be diagnosed with urinalysis sticks, which look at ketone levels in the urine. And if you're treating quite a lot of pregnancy sickness, it might be worth getting some of these from your chemist. They are easy to use, and they're little plastic dipstick. You get quite a lot in a bottle, so they'll go a long way. And if you just get her to try and pee on one of these sticks, and you'll find on a colour chart just how many ketones she's got. If she's got, I can't remember what the range is, but let's say there's 5 little bars. If she's got over 2 or 3 little bars of ketos showing up, she really does need to be referred to her midwife or GP for admission to hospital, because the ketones will likely get worse. And the way that it's treated is that she has a drip put up to correct this electrolyte imbalance, and usually she's given antiemetic medication as well, which is usually given intravenously at first, because these women cannot keep anything down. Once she's had her first couple of bags of fluids through her drip, she will feel so much better. They really feel ill. They might smell ketotic. As they walk past you into the clinic, you might get a smell of pear drops, and this ketones being excreted in their breath. TCM treatment is still appropriate, but it needs to be frequent. And the caution here is just to say, by all means treat them, and I urge you to, because it can make such a difference. But if they've really gone too far, then I'm afraid your treatment won't be able to help them until they've had this fluid imbalance corrected. So just to be aware of that. Once they've been to hospital, I hope they have an appointment with you as soon as possible afterwards to treat them and stop this happening again, because our experience with acupuncture is that it can make a massive difference to this condition being more manageable. It has a characteristic of going on the whole way through the pregnancy, unfortunately. So can you imagine being sick the whole way through and repeated hospital admissions? With acupuncture, you may not have been able to prevent the first couple of admissions, but you can probably prevent them having to keep going back into hospital and really improve the quality of their pregnancy. And I find that this is really important. So, I'm going to talk a little bit about the treatment in a minute, and I'm going to give you a couple of case studies to illustrate what can happen. Right. What can we do for hyperemesis? Well, I used to treat hyperemesis as other pregnancy sickness, just using my TCM picture, what's going on here, using points to address the disharmonies. And I got reasonable results, sometimes very good, sometimes not so good. And then I came across a treatment which Deborah Betts recommended to me, which is aimed at harmonizing Chong Mai by using points which she heard from a seminar by Kiku Matsumoto, who considers kidney 27, Shu Fu, and kidney 6, Jiao Hai, the endpoints of Chong Mai. And by using these endpoints to calm down this rebellious qi in Chong Mai, and also using points such as kidney 21, Yu Men, and severe cases, stomach 30, Qi Chong. Now, I know that's a point on the abdomen, but at that stage of the pregnancy, it's not a problem. Okay, so just point that out. I don't want to contradict myself, but stomach 30 is okay in the early stages with severe vomiting, but really only in severe cases, in my experience. Plus, you do obviously need to treat any patterns of disharmony, which we'll be talking about when we talk about nausea and vomiting. And you can consider using ear press needles to kidney 27 and kidney 6. Kidney 27 will help with the nausea, and kidney 6 will help with the vomiting. So you can put these on at the end of your treatment. The woman can go home with them in situ with advice. It's supposed to be spring here in the UK, although it's more like winter. So my ladies are coming in with boots on and shoes. So I tend not to put kidney 6 in, but I give them some spare press needles. You can use the these ones illustrated here, or those little round Pionex, serum Pionex ones, doesn't really matter. I give them some spares to go home with, and I tell the girls where to put the needles. And when they get home, if they're walking around the house with bare feet or flip-flops or whatever, they can wear kidney 6, or they can put those needles on when they go to bed at night. Okay, but they're not really going to want to wear them with boots or shoes because they rub, and we don't want to put them off using them. So just teach them where to put them, and they can use that as backup. And when they're feeling particularly rough, of course, they can use these press needles to just stimulate them gently with their finger, wake up the points, and give themselves a little mini treatment. And they will need that with this condition, because if you can only see them once a week, it's not enough. And again, we have women who come back and say, oh, I was okay until my little press needles fell off, or they came out, or they got sore, or whatever. And then their condition gets worse. So they do seem to make a big difference. It's very reassuring for them too, to have something to keep them going. So that's my way of approaching hyperemesis. It doesn't always work. Don't be too disappointed if it doesn't always work. Don't give up though. Keep going back, keep going over the patient's history, look at her tongue, check her pulse, what's going on, and see if there's something that you may need to address. But it can make a huge difference, and I'm going to talk about some cases in a minute to illustrate that. Is it possible to please just have a show of hands? Who's using this treatment for hyperemesis?
So again, just raising your hands if you've come across the kidney 27, kidney 6, kidney 21 combination with stomach 30 for hyperemesis. So just taking a moment there to raise your hands using the icon. Just another minute or so.
So Sarah, it looks like we've got 4 people, 14% of people on the line tonight who are familiar with that treatment.
Okay. Right, well, I hope you're, I should have asked, I hope you're finding it useful, but if you haven't been using it, then do give it a try. I've found it really has made a difference to my practice. So give it a try and see what you think, and it'd be very interesting to have feedback actually on that at some stage. My email will come up at the end, and if you want to contact me with your experiences of this, I'd love to hear from you. Okay.
We've had a comment come in, Sarah, from Gemma saying that with regards to the ear press needles, that she's found using ear seeds also really effective for sending pregnant women home with the ear seeds instead of the press needles.
Yep, thank you, Gemma. That's great. Yes, we do also use seeds. Again, you may have women who prefer not to have these little needles in, but seeds, yeah, they're great. Yeah, that's a very helpful comment. Thank you. Yeah, we do that too. Okay, so moving on, generally looking at the kind of background picture with nausea and vomiting. This disorder in Chiang Mai can lead to rebellious qi, which affects the descending of stomach qi, resulting in nausea and vomiting. So you can have, as I've said earlier on, your patient's pre-existing tendency to any of these conditions may be made worse during pregnancy. So just go through her case and see what you think is actually going on. Has she got a lot of stomach heat? Has she got heat showing on her tongue? Is she talking about heartburn, acid burning feeling going up into her mouth, all of those things? So you will tailor your treatment according to what you see in front of you. And emotional things as well. You know, is there a lot of anxiety and stress going on? Ask about what it's like when she's sick. It's not very nice talking about it, but it is important to be able to differentiate your pattern of disharmony. So if she's got a lot of, for instance, stomach deficiency with cold, she might be vomiting clear fluids, and she may feel cold. She'll have a pale, wet tongue, all of these things. It's the usual TCM approach, really. And so you use your points accordingly. interestingly, pericardium 6, NEG1, tends to come into, it can be used for all of these treatments. So if you're in doubt, consider using pericardium 6. But points, if there's a lot of Qi deficiency and cold, you could think about points like Ren 12, Zong 1, with a moxa stick, just gently warm Ren 12 for that stomach cold. And if she's got a lot of anger about being pregnancy and you feel she has stagnation of liver Qi, if her obstetric history is okay, you can use liver 3. She'll be irritable, she'll be retching, she might have a bitter taste in her mouth, and she may be vomiting bile. So look at her tongue, and if you feel that that's what's this liver Qi is affecting her stomach, then you might need liver 3. She may have a lot of phlegm. Some women walk in with real excess salivation. I've seen 2 women in my 24 years of treating this problem, who have literally walked in, and as I've said that sentence, they've spat into a tissue 3 times. It's extraordinary. They are almost foaming at the mouth, and when they vomit, there's a lot of phlegm. So stomach 40, of course, is going to be your main point of choice for that sort of condition. You may consider other points for damp. Spleen 9, for instance. You know these points. So just see what's in front of you and treating it as you would in anybody, bearing in mind, of course, the forbidden points. So I hope that's helpful. These are just suggestions, and they're things I've found useful. But of course, you will all have your own.
And Sarah, we've had a question come in about a series of point combinations, and that is stomach 21 with pericardium 6, CV12 and CV13. Have you got any thoughts about that for treating hyperemesis? Again, the points were stomach 21, pericardium 6, CV12 and CV13 as a combination.
Yeah, I mean, the CV points around CV12, 13, 14, they're all good for reducing rebellious stomach Qi. Yeah, I mean, I think if people have found point combinations that work for them, that's fantastic. And I think, as time goes by, you do tend to find a combination of points that suit you. But I still always try and individualize it, and you can use, I don't want this to sound prescriptive, but you may, if it's hyperemesis, consider using this Chongmai treatment. You could just perhaps start with that. If you've never met this woman before, you don't know how acupuncture sensitive she is, start with that, and then if necessary, build the treatment up. But yeah, those points sound fine, and if that practitioner's found those useful, then that's great. But again, I think it comes back to what's actually sitting in front of you. So yeah, that's great. Okay.
We've just had one more question about the clarification of avoiding the lower REN points. There was, is it the concern because of the proximity to the uterus, or is it because of their blood moving properties, the actual physiology of those lower REN points, and why you mentioned earlier that you would best to avoid them?
Yeah, it is more the. I think generally, actually, pregnant women don't like having needles in their lower tummy. They get very protective, quite understandably, towards their baby, even when it's very tiny. And generally, I find that they don't really want needles below their umbilicus. But of course, again, it depends on the individual point. But a lot of those lower abdominal points will affect the lower jiao, of course. That's where they're located. Some of them will have an effect on the blood in the uterus. Some of them will have effect on the Qi in that area. We haven't really got time to go into all the lower abdominal points, but it is a general acceptance that it's good to try and avoid them. And as I quoted earlier on, it is taken from the ancient texts as well. So I hope that's satisfactory for now.
That's great. Thanks, Sarah.
Okay, so The TCM approach and advice for treatment for sickness, things like treating once, preferably twice per week. And as I said earlier, with hyperemesis, you could even consider making that 3 times per week. But space the treatments out, give them a day's rest. So maybe Monday, Wednesday, Friday, Monday, whatever's suitable. Keep your needles in for 20 minutes as usual. Keep your points to a minimum and really focus on what you think is going on. And consider ear press needles or seeds or motion sickness bands to wear between the treatment. And you can see a picture there of a motion sickness band placed on pericardium 6. Your ladies may walk into the clinic with these on already. Just check that they've got them in the right place, because the instructions on the packet don't always look very clear to me. And so I quite often find that they've actually not got the bands over pericardium 6, so they're not really working very well. Another consideration with these is that depending on the woman's wrist, they may be too loose. They need really strong pressure on pericardium 6 for these bands to work. And so you may want to consider having pediatric bands. If it's the style that you can see here in the picture, they can get loose quite quickly. I have in my clinic, which I lend to my patients, some, I think they're called Acubands, and they're a different design. They have a Velcro tightening, and a Velcro fastening, and you can actually tighten them individually. And I have a set of those in my clinic, and I lend them out to patients. You can actually make sure that they go home with them at the point exactly over pericardium 6 and the right tightness. And then they just bring them back to me when they're feeling better. In your clinic, you want your bowl, tissues, and good ventilation, glass of water. And advise, they need to rest. I know this is difficult for most women, but they need to consider getting help with the kids, take time off work. Just because they're very early in pregnancy doesn't mean they have to be Wonder Woman. And if they're trying to work with this condition, they really push themselves. And if they're in a position to get some help, then get it. If they can get some friends to help with their children, or if they can get somebody to take their children to a preschool or something like that, they may tend to think, oh, I'm not well enough to take little Johnny off to preschool, so they don't go. So they end up looking after them all day, or trying to look after them while they're being sick. And I really stress that I think this is important. It's a really good idea to eat little and often to stabilise their blood sugar. These women can't manage 3 big meals a day, or even 1 or 2 big meals a day. They need to have little snacks available. This can be a problem again if they're working. I had a lady who worked in a supermarket. She didn't get any coffee break. She had to stand up working on a till. She didn't even have a chair. She didn't want her boss to know she was pregnant. So I suggested she just put something in her pocket just to nibble at. And actually, I don't feel it really matters that it's really high quality food at this stage. Even if she's just eating something like hula hoops, it's something to just settle her stomach will make a massive difference. And then she can eat more healthily later on when she's not being so sick. Fluids are important. Sip frequently, no gulping even when they're thirsty, because it'll just come straight back up. So to have a glass of water or whatever fluid they can manage. Again, if it's a fizzy drink, it's not ideal, but if it's the only thing they can manage, then that's better than nothing. So have it nearby, have a sip frequently. And as I said earlier on, I always have some water in my clinic that they can just wet their mouth with. They'll be very dry, particularly if they've got hyperemesis. Soups are wonderful at this stage. Obviously homemade is better, but anything that is easily digestible, they may find that they can manage a little bit of soup, and hopefully if it's got plenty of nutrition in it, that'll really help avoid their electrolytes going out of balance. And snacks. Avoid strong smells. It can make them really sick. You may find that they can't go in the kitchen and that their partner has to cook for them. What a shame. Ginger and peppermint issue. I'm afraid a lot of midwives will advise pregnant women with sickness to have ginger. And of course, it's not always appropriate. If they've got stomach heat, it makes them worse. So just give them an idea about if they've got a lot of stomach heat, you look at their tongue, to try peppermint tea, peppermint tisane, whatever. And you may find that's a turning point for them. If they've got a lot of stomach cold, of course, then ginger may well be the answer. Ginger tea or whatever. And they must seek help if they're dehydrated and they can't stop vomiting. So a case history I have for
So
you.
we've just had a question come in about, so just before we move on to the case history, you've got the slide there that shows the motion sickness band and it's reference to Pericardium 6. And we've just had a comment come in about whether Pericardium 6 has a strong role on moving chi in the liver, and whether that's safe to use in pregnancy, whether you've had any experience or problems from using Pericardium 6 ever.
No, not at all. There's a massive amount of research on Pericardium 6, thanks to an anaesthetist called Dundee, who went to China and noticed how much this point was helping sickness, and came back and did a lot of research on using Pericardium 6 for post-operative vomiting, post-anaesthetic vomiting, chemotherapy-induced vomiting, and pregnancy vomiting. And if you look into the literature, I've written a briefing paper on sickness in pregnancy, which you can find on the British Acupuncture Council website. It's obstetrics #1. It's out of date now, but there's an awful lot of research in there, really inspired by this guy. And it led to a cascade of other studies on using acupressure and acupuncture on Pericardium 6, including safety in pregnancy. And it seems absolutely fine. I've never had a problem with it, touch wood. Yes, it does have an effect on liver chi, but not in the way that we wouldn't want it to happen, if that's, excuse my English there. And interestingly, one of the other studies looked at the actual mechanism of Pericardium 6 physiologically, and it showed that Pericardium 6 actually has an effect on gastric rhythm. The rhythm of the stomach can be measured electronically in the same way you might pick up an ECG or an EEG. And gastric rhythm is abnormal in people with nausea and vomiting. And they found that when they needled Pericardium 6, that this rhythm was normalized. So there's a definite physiological explanation for how this point can affect the stomach. But as I say, in pregnancy, it's absolutely fine, and it comes into all the point prescriptions. So I hope that's useful.
That's wonderful. And just to mention to everybody that what we will be doing is making, of course, a copy of this presentation available as a PDF. And also any references which Sarah has mentioned, we will dig up and put in the members area after the webinar. So certainly we can go through and have a look for some of those articles you've mentioned, which is terrific. Thanks for that, Sarah.
Okay. I'd like to tell you about Kerry. Kerry was a lady I saw first in November 2009. It's her second baby. And she had hyperemesis from the 7th week of pregnancy. She had a little girl called Eva at home, and she had had acupuncture with one of my colleagues in that pregnancy, which helped, but she did continue to have nausea the whole way through the pregnancy. When I saw her, she had had repeated admissions to hospital for rehydration, and they had the dreadful experience of having to decide whether to continue with the pregnancy of this much wanted baby when her weight had dropped to 6 stone by the 16th week. I was quite alarmed when I met her at her size. She was referred to us, and I'm very pleased to say that she had no more admissions following treatment, and a marked improvement in her sickness. And just as an aside, her husband used acupressure in labour with great results, and you can actually see Kerry and her husband on the Deborah Betts acupressure DVD, just as an aside. She was so pleased with her treatment. She was such a lovely girl. It was such a pleasure to treat her. They really did want this baby, so the thought that they were considering termination I find is absolutely dreadful. So she was so pleased that she actually, a long time after she'd had the baby, ran a Plymouth half marathon and raised £528 towards our service, which was great. And you can read her story if you're interested on her Just Giving site. It's still up there. She also found great support from a forum called helpher.org, which stands for Hyperemesis Education and Research. Kerry commented that there was very little help out there. That was, I found very sad, that the approach to these women is just to, it seems to be very medicalized. You get them in, put the drip up, sort them out, send them home. Get them in, put the drip up, and this goes on. Kerry found that she was looking everywhere for more support, and there is a forum on the Help Her website, and you can these girls can find support and help through talking to other women and around the world who've got this problem. There was, I think it was last year or maybe the year before, the first conference on hyperemesis in this country, which again I found quite alarming, and I have actually offered to give them a presentation if they have another conference on acupuncture, because it wasn't being discussed, and I think we need to, as practitioners, get a lot of awareness out there just about how good this treatment can be for this awful condition. Okay, so that's Kerry's rather nice story. Another lady I saw, not with hyperemesis this time, but with nausea and vomiting, fairly severe, but not classed as hyperemesis. But Dawn was interesting. You can see her slightly later in the pregnancy here, having treatment. And she had, when she first came to see me, was still breastfeeding a 2.5-year-old baby or toddler, and it was her fourth. That was her fourth baby. This was her fifth pregnancy, and so breastfeeding can consume liver blood, and her picture was very much of a liver blood deficiency type. And you can see I've got needles and liver 8 there to tonify liver blood. So that's an example of tailoring the treatment to the patient, and she did remarkably well even after the first treatment. And I also recommended that she stop breastfeeding. And another story is of a girl called Kimberly, who I saw yesterday, so very current. Kimberly is in her second pregnancy, and she came to see me on the 17th of April. So yesterday was her third treatment with me. She's already got a 3-year-old at home called Callum, and had terrible hyperemesis in that pregnancy, and was admitted to hospital for most of it. And once during that pregnancy, she was in hospital for 7 weeks. This is a serious condition. So she's been referred to us this time, and I first saw her, she was already 21 weeks and had already been admitted 3 times. And so this hyperemesis had started at 7 weeks in the pregnancy, which is pretty early on. She has been prescribed cyclizine 3 times a day. I'm sorry for those of you who may not have the same drug names, but cyclizine 3 times a day, ondansetron 3 times a day, and omeprazole at night. Nothing was helping. None of these drugs were helping. And again, pregnant women don't tend to like to take drugs. The awful thalidomide disaster really highlighted just how vulnerable that baby is. Constant headaches, and was being sick 30 times per day. She was dehydrated and trying to manage cereal, a bit of soup, crackers, toast, and sipping water. She was already dry, but she improved after her first treatment. If you're interested, the points I used, having checked out the rest of her case history, were the Chong Mai points, kidney 27, kidney 6. I used REN 12 with her, and I used stomach 44 because she also had some stomach heat, and I used Pericardium 6. There was a marked improvement in her nausea during the treatment. I gave her an advice sheet about eating little and often, etc. And after that first treatment, she had 4 days without sickness at all, which was very unusual. She'd eaten and generally feeling a little bit better. Yesterday I saw her, and she'd only been sick once in the previous week, which was marked improvement from being sick 30 times a day. And generally she was able to get out a bit more and eating much better and drinking much better. So I'm going to carry on seeing her. I'm also treating her for headaches, but I'm not going to dwell on that at the moment. But just a lovely example of just what a difference this treatment can make. So I hope that's encouraging. So moving on. Headaches in the first trimester, fairly common in my experience. They may be migraines, so they may be a woman who's had migraines before she got pregnant and they've got worse, possibly due to the hormonal effects or whatever TCM picture is going on, or it may be new migraines that they've never had before. So the treatment really is as in a non-pregnant person, but bearing in mind the forbidden points, as we've discussed before. So you may be tempted to use certain points, just to be careful that they're safe to use in pregnancy, and try and choose fewer points than you might in somebody who wasn't pregnant. As I've said earlier, pregnant women, in my experience, respond beautifully to acupuncture, and you may find that you just don't need to do the same strength of treatment that you might in someone who's not pregnant. And gentle needle technique. I find that the most common presentation for headaches in early pregnancy is related to the stomach channel, their frontal headaches, and also fairly common is the liver yang rising type of headache, which presents on the temples, or there may be, of course, a combination. Liver yang rising, well, this whole emotional thing about early pregnancy, the changes, all of those issues about work, relationships, etc. They're going to give you a pretty good clue as to what's going on and why they're getting these headaches. They respond very well. They're very grateful, and in some cases they can be quite severe. So acupuncture treatment at this stage is really useful. But bearing in mind that, you know, if it's an excess headache, and you know, you just need to be a little bit more cautious in doing strong moving treatments. The sort of patient I tend to see, there's a lady who's been to me now for 2 pregnancies. She's just had her second baby, and through both her pregnancies, I saw her feel severe headaches, occasionally migraines. She's a school teacher. She's full-time, so fairly stressful job, on her feet all day, probably not able to eat well. She exercises a lot. She's married to a fitness instructor. She keeps herself very fit, and I felt that maybe she was doing a little bit too much of that. But all of these things I felt were having an effect. She has quite a stressful job and was quite a stressful person, quite stressy, if you know what I mean by that. And we found that the acupuncture really helped her headaches tremendously, along with some advice. And if I was away on holiday and she didn't get treatment for a couple of weeks, her headaches did come back. Our aim with treatment in pregnancy is to try and stop seeing women. So as soon as they're feeling better, we stop seeing them. Unfortunately, we have a very long waiting list, so it's quite important that we stop seeing people as soon as possible to get new ladies in off the waiting list. But they all have an ability to come back to us, so we call it putting them on SOS, call us if you need us. And so this lady, Suzanne, would be in a position where she could come back to us if the headaches did get worse. So that's the sort of picture we'd see. But generally, I find that treating headaches in the first trimester of pregnancy, they do very well, and you may not see them again, hopefully. Okay, how many people seeing headaches in pregnancy and have good experiences with treatment? Could we just have another show of hands on that one?
So we can take you a moment to raise your hand if you're seeing headaches in pregnancy, in those early stages of pregnancy. So I had a question for you just while people are raising their hands there about, you mentioned the diet and lifestyle. And I had a question for you about caffeine and your thoughts on, you know, whether to advise people to stop drinking caffeine entirely, or you know, what your thoughts are on that, because of course one of the things we do know is people who are withdrawing from caffeine can often have headaches as a side effect, certainly, you know, just in the early stages while they're detoxing. Have you had any experience with the correlation between caffeine and headaches?
Yes, that's a very interesting point, actually, Catherine. I guess it depends on the woman, because if she's also got sickness, and it is something that tends to come in the clinic, a lot of the women who come for sickness also have headaches. And because they're feeling sick, they can't drink tea or coffee, so they may well be withdrawing from caffeine. And they will often comment, oh, I can't drink coffee. I used to drink, you know, several cups a day, and I can't stand it at the moment. They don't like the taste of it, and the same with tea. So yes, there may be a withdrawal issue going on there. Or it may be that they are still drinking it and haven't considered cutting it down. So when I'm asking them about their diet, I do ask about, I ask them for an average day intake of food and drink. So I want them to tell me what do they have through the day, and sometimes that will give me some clues as to whether I need to give them some advice on caffeine. There's something coming into my head here about a possible link with caffeine and miscarriage, but it's a kind of little foggy memory. I'd have to look into it, but if anyone else you know, can write a comment on that, that'd be interesting. But somewhere in my head, I have a feeling that there's a link between a lot of caffeine and potential miscarriage. But yeah, I think dietary and lifestyle advice are hugely important, and it may be that they are drinking too much and taking too much caffeine in, or indeed withdrawing from it. And of course, you have to consider compliance. You know, that some of these women will take on board what you suggest, and some of them won't have any of it.
So Sarah, just under a third of our audience tonight are familiar with treatment of headaches at this stage of pregnancy.
Okay, thank you. Yeah, so that reflects what we're seeing. It's a fairly common problem. Okay. Now, constipation is an issue in the first trimester. It's an issue throughout pregnancy for some women, but particularly common in the first trimester. And it's an interesting one, this, because we're talking about, you know, moving in the lower jiao here, which obviously needs to be done with great caution. Constipation is obviously a difficulty in frequency of bowel movements, and we know that the progesterone in particular has an effect on the smooth muscle of the gut. And while those hormones are higher in circulation in the first trimester, they will be causing things like constipation. Maybe in somebody who's previously had a completely normal bowel habit, or in somebody who had a tendency to constipation before they got pregnant, and the pregnancy makes it worse. But a very distressing condition in some cases, and one that a lot of people don't particularly feel comfortable talking about. It is possible for women to actually have to be admitted antenatally with constipation, certainly later in the pregnancy, and that's not good, particularly if you've got children at home that you have to leave just to have a problem like this sorted out. They will be given medication. Their iron tablets, if they're taking them, can affect the bowel habit. It can either give them very loose stools, or it can cause constipation. Fibrogel can be prescribed to try and get them to go to the loo, and also laxatives, but that's unusual because they have this strong effect on the gut, and you have to be a little bit careful in the first trimester using strong aperients. So there's the old question of what is normal, and again, you know, I remember this very clearly from my acupuncture training. It's no good saying, "Are your bowels normal?" because they'll just say yes or no. You actually have to ask them, how often do you have your bowels open? How often do you go to the loo? And you may find that women say, "Oh, I go once a week, that's normal for me." Well, it may be normal for her, but it's not normal. And again, we may get women referred to as just for constipation, or the constipation comes out in part of their case history when we're treating them for other things like pelvic pain or sickness or headaches or whatever. and I think it's very important to address it. I have had ladies who've come to see me who only go once a week, and in treating the constipation as part of their general treatment, they find fantastic results, that they start going once every other day, once every day, once every 3 days, whatever. And it may be the first time in their life that they've been able to go to the loo like this. And with pregnancy, you don't really want any more extra bloating or feeling congested in your lower abdomen, because the pregnancy is already doing that very nicely for you. Okay, so quite important to sort of pin that down, really, and address it. So these are things I've found useful for treating constipation. The main point is Sanjiao 6, triple burner 6, Jigu, an amazing point in my experience for constipation. And if it, in doubt of which syndrome is presenting in front of you, I would always use that point in your prescription. I find it absolutely amazing, and sometimes just that one alone will have an amazing effect. Quite often there's some heat in the large intestine, so colon 11, large intestine 11, is a nice complementary point with Sanjiao 6. And there's a woman I'm seeing at the moment with pelvic pain who also has constipation, and Sanjiao 6 had a miraculous result. She was beaming with what it did for her, until a few weeks later it wasn't seeming to have the same effect. So we've added in colon 11 because I felt there was some heat in her large intestine, and she's back on track again. So sometimes you need to add in an extra point, or look again at what's in front of you and think, which point do I need here? So you can see the syndromes there: stagnation of liver Qi, you may want liver 3. If you feel she's got blood deficiency, stomach 36, kidney yang deficiency, kidney 7, and kidney yin deficiency, kidney 6. Again, just see what's in front of you. And it's okay to use these in the first trimester, but just use gentle needle technique. You may find that's all they need, alongside some advice. Hopefully, if they're not feeling too sick, that they can manage to increase their intake of fruit, vegetables and fibre, and really drink plenty to help counteract this constipation. And exercise is useful, and spend time on the loo. This modern rushing around lifestyle we have means that people aren't taking time. I encourage them to take a magazine or a book and actually just go and sit there and wait and let it happen naturally. If you think about it, if somebody's really constipated, they're having to sit there and really strain. So that's not good. What you're doing with your acupuncture is making that less necessary, so that they're likely to be straining much less by your treatment, helping the constipation resolve and their bowel movement to become easier. And this is what they describe, that it's easier, it's less painful, and they're not having to strain so much on the loo. So.
And Sarah, have you had much experience using stomach 25 for constipation in the early stages of pregnancy?
No, I don't. And again, I think it's because I like to try and avoid the abdominal points. It would probably be okay, but I find I don't really need it, actually. I do pretty well with these point combinations here. Yeah.
Okay, thank you.
Okay, so that's all I'm going to say about constipation at the moment. Moving on to fatigue. A lot of women will feel incredibly tired and fatigued and look like this lady here in the early stages of pregnancy. Their body's adapting to these huge physiological and hormonal changes. There's psychological aspects, as we've talked about, work issues, Have they admitted that they're pregnant? Are they having to hide the fact that they're pregnant from maybe their family, maybe their work colleagues? That they may be really struggling, and that can be very tiring, cause a lot of fatigue. They might have other children to look after. If they're feeling sick or even just nauseous, maybe they're having headaches, any of the things we've already discussed, having to look after other kids running around or get other kids to school or any of these things. Any mums will know, sorry Catherine, just how hard work this can be. And if you're in early pregnancy and not feeling great, then it can be a bit of a struggle. And of course, their pre-pregnancy health is significant here. Were they already Qi deficient? Were they already blood deficient? Were they already a bit fatigued? Was life a bit of a struggle? They're not able to get out and get some fresh air and exercise. All of these things will contribute to how they present in these first precious months of pregnancy. So the sort of TCM patterns you're looking for: Qi deficiency, Yang deficiency, Yin deficiency, blood deficiency, possibly liver Qi stagnation. So have a look at what you have in front of you. Differentiate which Zhang involved, and just some fairly obvious suggestions here. You'll be very familiar with this, but things like stomach 36, good point for things like Qi deficiency, spleen, Yang deficiency, and blood deficiency. You can think of the back shu points for affected organs with Yin or Yang deficiency, so points such as bladder 13, bladder 15, bladder 23, and liver Qi stagnation, points such as liver 3. I find that dietary and lifestyle advice is essential, and sometimes it's hard to believe how women can carry on or try to carry on and not be aware that they may need to really consider how they're living their life, even though they're only in the very first stages of pregnancy. I'd like to illustrate that with a story about a girl who was actually having repeated miscarriages, and when she came to see me, it was for anxiety about losing the pregnancy again. She was 9 weeks pregnant when I saw her, but she had actually already lost that baby at 7 weeks. She hadn't realised when she came to see me. But when I did her case history, I was talking about how well she slept, and she said, well, it's okay except the days when I have to get up for a breakfast meeting. Bearing in mind I'm talking to you from rural Devon, not busy cities such as London, I was quite interested that this woman was having these breakfast meetings, and asked her how often. She was getting up at 5:30 in the morning 3 days a week, and so I assumed that she'd be finishing work early because of this, but not at all. She was still working until early evening, and I found, well, immediately alarm bells were ringing, and I suggested to her that had she ever considered resting a bit more in the early stages of pregnancy, and had anybody advised her about this? And she said no, they hadn't. They just told her to, get pregnant again, have another try. Anyway, I gave her a treatment, and I suggested to her that when I found out that she'd lost that baby, that if she got pregnant again, she should go to see her GP and ask to go off sick, and surround herself with books and magazines, eat well, rest a lot, and do nothing. Because she had the picture of real Qi deficiency. She looked Qi deficient, she looked damp, she was overweight, she was tired, she just really needed to rest. And I'm pleased to say that I saw her for treatment, and she did actually carry that baby right through to term, having had 4 or 5 miscarriages previously. So really important that you may be, as their practitioner, the only person or the first person to make suggestions about dietary and lifestyle advice. And as acupuncturists, I think it's such an important part of our work. It's not just about putting needles in. And I think it's a very rewarding aspect to our practice. So now we need to talk about bleeding in early pregnancy. This is reasonably common. It can be heavy spotting, or it can be a heavier flow. Some women have a bit of spotting when their period would have been due. Of course, it can be a miscarriage if it's early pregnancy. Later on, it could be separation of the placenta, particularly with the placenta previa, which you've got a little diagram of there rather nicely. The diagnosis of what's going on in early pregnancy with bleeding is by ultrasound scan to try and determine any cause, but also the viability of the fetus. So in other words, is the pregnancy still viable? And the treatment will depend on the outcome of this scan. It may be mild or severe, but it's abnormal, and it must be referred to the midwife or GP. And it may be that it's the presentation of an ectopic pregnancy, which we're just about to discuss.
And Sarah, just before we move on, if you could just take us through that diagram of what placenta previa is and what the implications are, and perhaps how you might detect that, whether that's something that you know that to recognise the signs and symptoms for.
Okay, Catherine. Well, I'm very happy to do that. It's not really a problem in the first trimester, but basically on the first diagram there on the left, the normal placenta is, in this case, implanted sort of laterally and fairly high up in the uterus, and not a problem. The second diagram is of a marginal placenta previa, and this is where the bottom edge of the placenta is just beginning to encroach on the cervix. The placenta tends to rise up during pregnancy as the weeks go by, so it's not a problem in the early pregnancy, and it will quite often move up out the way. So these women will have repeated scans to see where the placenta is located. So after sort of 28, 30, 32 weeks, you're more interested in where the placenta has ended up. The main problem is with the third diagram, which is a complete placenta previa, and this is where the placenta has implanted over the cervix, and these don't move out the way. They are a problem because as the baby gets bigger, puts weight on this placenta, because it's sitting on top of it, if you like, can cause bleeding, and certainly later in the pregnancy it can be a real issue because these women can hemorrhage. So these women have to have a cesarean section. There's no way that baby can be born vaginally. Okay, so I'll just leave it at that for now, but it's not an issue early in the pregnancy in terms of bleeding, in that they wouldn't be able to do anything about it. All they would be able to do would be to diagnose it early on. Okay.
That's great, thank you.
Okay, so if a woman comes to you in early pregnancy with bleeding, then you do need to refer her and get an idea about what's going on. You could consider using points maybe such as do 20, Weichway, Governor 20, to raise chi, to hold chi up, if you felt it was appropriate, but or points for anxiety, because she's certainly going to be anxious. You could consider Heart 7 Shen Men or Ear Shen Men, to perhaps put a little seed or a little stud needle on Shen Men in the ear before she leaves you to go to have her scan. But I wouldn't do too much more at that stage until you really know what's going on. But I would like to talk really more about abdominal pain, because this could be an ectopic pregnancy. Now, ectopic pregnancies are nasty. They're life-threatening, and they can present with just bleeding. So this is why she needs to go off and have some investigations done. I said to you earlier on about the early pregnancy units or day assessment units, and it's something that I can give Catherine some information on for you guys later on, about units in the UK. So that would be the sort of place that she would end up having this early pregnancy scan. So there's a crossover between bleeding in pregnancy and abdominal pain. okay, when it relates to ectopic pregnancy. A colicky cramping pain on one side of the abdomen can be a sign of ectopic pregnancy. It can spread, or it can be worse with opening the bowels and coughing. And as you can see from the diagram here, an ectopic pregnancy is where the fertilized egg implants in the fallopian tube and starts to grow there because there's nourishment from blood, etc. So the embryo can start to grow in the tube, and the danger is that as it grows, it can risk rupturing the fallopian tube, causing hemorrhage. There's an awful lot of blood around this area, so it can be life-threatening. So I hope you can see that quite clearly from the diagram. It usually occurs around 6 to 10 weeks, and the mother can show signs of shock. This is when the fallopian tube is beginning to rupture. She will have a rapid weak pulse. She may be sweating, and if it's really going, then she's going to collapse from heavy bleeding into the pelvis. There isn't any TCM treatment for this, although there have been some studies published in 1993 in Chinese journals using herbs, but I'm afraid I don't know any more about that, and I'm also not herb trained, so I should just leave that there for you to follow up if you're interested. But I'd like to urge you that this is a life-threatening event, and you must seek medical advice or refer her to hospital urgently. Now, I don't mean to be scaremongering, but if somebody comes into your clinic, just to look out for all these things and exclude them. But the main thing with ectopic pregnancy is it can present in very different ways, and it's not always textbook. She may not always have pain on one side. She might have it on both sides. She may not have any pain. She might just be bleeding. She may not have any signs of shock. If you're not sure, it's always better to be cautious. I would actually share with you that I have actually had an ectopic pregnancy myself, and I had no idea I was even pregnant. And I was very fortunate to be at work doing my acupuncture clinic when I started getting tremendous stabbing pains on one side. I hadn't even missed a period. I'd had a rather weird period and was having some sort of brown blood loss, but I had no idea that this was going on, and it was only because I was at the hospital, and as it was getting worse, and there I was doing my acupuncture clinic, trying to hide from my women that I would suddenly get this stab, trying not to show anything to them. And I wanted to try and get through my 10 women. And at the end of the day, spoken to one of our registrars or consultants, and she said, well, it's probably nothing, but maybe we'll just do a quick scan. And there was the shock of a 6-week ectopic pregnancy. So straight into hospital. So you can be foxed. That's the point. But it's always worth checking it out, making sure that it's excuse me, it's not an ectopic pregnancy. If you consider it might be, then check it out. If it's not an ectopic pregnancy, by all means, you can treat abdominal pain in early pregnancy. A lot of women get like stretching pains in the lower abdomen, but they usually resolve fairly well. It may be related to pelvic pain. Once you've excluded ectopic pregnancy, then just treat them like you would, you know, with all the cautions of treating early pregnancy, whatever you feel she needs. Okay, so moving on now to threatened miscarriage. I hope you're all okay. We're nearly there. I don't have much experience of treating threatened miscarriage, but it is a condition that you may see in your clinics. The reason I don't have much experience of it is that it's not referred to us. It's something that's dealt with by our early pregnancy unit, and I think mainly it's something that may not be seen very much by community midwives. It's usually picked up by a GP, and it may not be something that they consider acupuncture can be helpful for. We may have to do something about this, because I'm going to refer to some work in a minute that makes it blindingly obvious that it's something that we need to flag up much more as a treatment for threatened miscarriage. So just to run through the symptoms, the woman may be presenting with bleeding, low backache, abdominal cramps, and she needs to be checked to see if the fetus is still viable. So again, an ultrasound scan will show whether this threatened miscarriage is able to possibly continue to full pregnancy, or whether she has already lost the baby. So that's the first thing. If the baby's still fine, then you can look at TCM approach. What's going on? Is it kidney yin or yang shu? Is she qi or blood deficient, or both? Is there spleen qi sinking, or is there blood heat? All of these may be reasons for threatened miscarriage. So the main points are DO 20 by Wade, Gutler vessel 20, kidney 9, Zubin, and you can use Ren 4, Guan Yuan, again, a low abdominal point, but Deborah Betts is treating this a lot and finding that that's a good point to use for threatened miscarriage, plus points according to the underlying disharmony. And interesting here, we have, again, diet and lifestyle, rest, no alcohol, and reduction of caffeine. So I think that little bubble in my head must have come from this link with threatened miscarriage. Now, Deborah Betts in New Zealand is currently doing a PhD on acupuncture and threatened miscarriage. She's really busy with it. It's a fascinating project. She has an article published. You can get access to it, and here's the link. This is the abstract. And they are currently carrying out a study on acupuncture and threatened miscarriage, which is part of her PhD, which is going to be fascinating work. In this article, they discuss how threatened miscarriage is really so poorly addressed, and that women tend to be told, well, it's a wait and see type of approach. And that we know from the effects of acupuncture in infertility treatment that there are positive effects on the uterus and blood flow to the uterus. So it is likely that this is a good approach for threatened miscarriage. They discuss how acupuncture and supportive care really does need addressing in a much better way. So maybe worth you getting hold of the full article. It is freely available on this site, and you can read how they are approaching this work, looking at beneficial hormonal responses from acupuncture, the fact that 50% to 70% of the women who miscarry do so because of chromosomal abnormalities, but what percentage of those others, for non-explained reasons, could be helped by treatment. And of course, as they proceed with their study, it'll be interesting to see the effect of acupuncture on threatened miscarriage. So it's a work in progress, and I think it's going to be very exciting.
And Sarah, I've just wanted to let the audience know that I've put a link to that article in the chat pad. So again, if you're interested in reading that article, which has only just recently been released, you can find that link in the chat pad on the right-hand side there.
Okay, thank you. How many of you are actually treating, if we have another show of hands, please, treating threatened miscarriage with acupuncture in your clinics?
So again, just taking a moment to raise your hands if any of your patients that are coming in.
Another few seconds. And Sarah, 15% of the audience are treating threatened miscarriage at the moment.
Okay. Yeah. So that's interesting. I wonder how many, if you read this paper and when we get the results of Deborah's trial, be interesting to see. I expect that number will shoot up, hopefully. Okay. So moving on now, just to mention urinary symptoms. Because of these effects of the hormones, as I said earlier on, they have an effect on the whole physiology of the woman in this first trimester, including the urethra and ureters, the whole of the renal tract. Just to kind of flag up that somebody who has a lot of urinary tract infections may present to you in the first trimester, and just to say that it's important to be aware of the effect that UTIs can have in pregnancy, which is different to non-pregnant women. They can cause miscarriage. They can be asymptomatic. She may not present with burning, painful urination, frequent urination, all of those things we associate with urinary tract infections. There is a risk of premature labour later in pregnancy. It's quite a common cause for prem labour. And the risk, of course, as well, is that there can be ascending infection to the kidneys because of this dilatation of the ureters, that an infection in the bladder can go upwards to the kidneys. And of course, that can cause renal infection, resulting in fever, abdominal back pain, and frequency and painful urination. And actually, these women, if they have renal infection, will need admitting for bed rest and antibiotics, usually intravenously. And later in pregnancy, they would have fetal monitoring. So just to flag that up really, and say that it can be treated, but to treat it like you normally would, it's usually damp heat in the bladder, but not always. Points such as spleen 9, yin ling chuan, and bladder 39, wei yang, can be used. Plus points according to the differentiation. So again, see what's in front of you. They often have an underlying kidney yang deficiency when they have frequent recurrence of UTIs. So you may need to address that. You can think of points like bladder 23 and spleen 9 to remove potential damp heat as a preventative measure. With maybe if you have a patient who is considering getting pregnant, who has a lot of urinary tract infections, you could consider this kind of approach to try and clear it. Maybe you're treating somebody for infertility, for instance, who has a tendency to urinary infections. And of course, with infertility, it's even more precious baby than they are already. So anything you can do to help build them up and get them in good condition before pregnancy is fantastic by using this sort of approach for urinary infections. And if you're treating her in pregnancy and she's not responding to your treatment in a couple of days, it's important to refer her for medical treatment if she's not already having it, due to this increased risk of spread to the kidneys. So just to say that you may need a more cautious approach. Okay, so just to go back to the red flags, abdominal pain may be a sign of miscarriage, threatened miscarriage, ectopic pregnancy. It may be just completely innocent, which is fantastic and treatable, but please just remember that it could be one of those more serious conditions, and treatment may be possible or appropriate alongside conventional management of these conditions, but again, you need to know what you're dealing with, so it's really about getting a diagnosis. Bleeding in the first trimester is not normal. Again, it needs to be checked out to make sure that the fetus is still viable, still alive, and to make sure that the bleeding isn't coming from, or to try and find where the bleeding is coming from and how severe it is. Hyperemesis with dehydration, again, you may find that by the time they get to you, they're too far gone with their hyperemesis and they won't respond to treatment unless they're rehydrated first. Again, you can treat them, and I really encourage you to treat them alongside and after conventional treatment. But you may find that you're seeing these women frequently through their pregnancy to support them. They may still be sick, maybe once a day. That's fine. You may not be able to get gold standard with this. What you're preventing, though, is repeated admissions, and they often will carry on being severely sick without acupuncture. So you're still going to be doing an awful lot for them. And again, just to be cautious with urinary tract infections in pregnancy because of this increased risk of miscarriage. There may be time now for some questions. I'll leave that up to our panel help people. And if you have any queries that I can be of any help with, I'm very happy for you to email me. There's my email on the screen. And I hope you all have a very successful time treating pregnancy, first trimester acupuncture. Thank you.
That's wonderful. Thank you, Sarah. That was a terrific presentation. Do we have any questions from the audience? If you'd like to type those into your chat pad, you know, it's certainly an area that is becoming very popular. I think there's a tendency now with pregnant women not wanting to obviously take Western pharmaceutical medications, so looking for alternatives, and acupuncture obviously proving its place as a safe and effective treatment option.
Sarah, I had a question just about multidimensional management, whether you find that you're working frequently with other kinds of practitioners treating women in the first trimester of pregnancy with these sorts of conditions.
So you mean like other complementary practitioners?
Other complementary practitioners, or whether you're working more frequently with just the medical GP or medical specialists, but also particularly other allied health professionals.
Right. Yeah. Well, I have two hats really. I have my hospital practice, which again, you know, I could get referrals for things like sickness, but they don't tend to think of us, as I said, for things like threatened miscarriage. So that's a little bit variable. And in my private practice, I work from home, so I'm not working alongside osteopaths, chiropractors, whatever. I would find myself sometimes later in pregnancy working alongside perhaps osteopaths or physios for pelvic pain. And I don't see any particular problem with that, except to say that you sometimes need to know who's doing what. So sometimes it's appropriate to suggest that the patient may try one thing and then another, so that you can see actually more clearly what's happening. But kind of linked to that in a way, maybe just when I've been doing some postgraduate teaching, I've found people ask me about how they can get access to more of this kind of work, and a suggestion may be to consider, if you're not doing it already, trying to perhaps give talks to local maternity units or midwives, and talk about the benefits of acupuncture in pregnancy in general, of course, but certainly in the first trimester, because you know, people may not consider that acupuncture can be useful. So that might be one way around it. And another thing I recommend, which I do in my private practice, is to consider writing to the patient's GP, with her permission, of course. But if she's happy for you to contact her GP, you can send, and I have a template for this, if Catherine would like me to pass it on. You can send a polite letter just saying, "Dear Dr. So-and-so, I have seen Sarah today for treatment of sickness in early pregnancy." And you can give a little bit more information, and that you're finding that the acupuncture is very helpful, and you're writing to just inform them. And it opens up channels of communication. It also will tell an awful lot more GPs that acupuncture can be helpful, and it's quite professional to actually send a letter like that. So I hope that might be useful.
Great, thank you. And just one other point, you mentioned the importance of dietary and lifestyle advice. Do you give any specific advice regarding exercise during this period?
Yes, good question. I think it's very individual again. I think it depends on her obstetric history. If it's her first baby, I would tend to be cautious because you don't know how good she is at holding on to a baby if she's never had one before. If she's fit and well, there's no reason why she shouldn't continue moderate exercise. But if she's really hammering it at the gym and doing what we would consider a high level of exercise, I would certainly suggest that she tones that down. And of course, in somebody who's got a history of miscarriage, they really do, they need to rest. But again, look at the woman from the TCM perspective. It may be that she actually needs to do more exercise. If she's got a lot of stagnation of liver chi, for instance, if she's the sort of pent-up, angry kind of person who is sighing a lot and had raging PMT every month, and headaches, that actually taking a bit of a walk might be useful, or doing a bit of a walk and a bit of meditation or something. Again, I think it needs to be individualised.
Great, thank you.
Thanks, Sarah. We've had a couple of questions come in also. Is if after treatment the sickness resolves, do you continue the treatment, or do you then stop?
No, I tend to stop. Two reasons. Well, at the hospital because of our waiting list, but I find that once you've, and I find this a lot with acupuncture, I don't know if people agree with me, but very often when you've tweaked that button, if you like, when you've altered that chi flow, when you've got things, moving more smoothly or whatever needed to be done, then that's it, job done really. In pregnancy in particular, if they continue to take care, usually they're fine. They may get sickness again later on in the pregnancy, but I'm talking about kind of 34, 35, 36 weeks. And at that stage, I find it's much more mechanical. It's the pressure of the big pregnant tummy pushing up on their stomach. And there's, you can try treating it, but you may not find a decent sort of easy TCM cause, if you like. So no, I tend to stop seeing them, and actually in my private practice I tend to stop seeing them, but I always say, please contact me as soon as you feel it might be coming back, and then I would get them back into my clinic as soon as possible. But no, they don't need to carry on seeing you, in my experience.
Great. And at what point during the pregnancy, you mentioned at what point physiologically the body changes shape and the pressure on the stomach. At what point is it best not to lay the patient down on their back in the later stages of pregnancy? Yes.
Again, it depends on the woman, but you're going to start getting more pressure on the inferior vena cava, and therefore potentially dropping her blood pressure. It varies tremendously, but you could say as early as 28 weeks, but more likely something like 32 weeks onwards, the baby's beginning to press down. And of course, it depends on her blood pressure already. Blood pressure tends to drop in pregnancy because of this hemodilution. So if you add into that anxiety about having acupuncture, maybe fear about it being the first treatment, maybe it's a stuffy hot room. If you lie a pregnant woman down too flat, they will quickly get postural hypertension. It looks a little bit like needle shock, but they go pale, clammy, sweaty. They go, oh, I feel awful. I used to pull all the needles out, but I'm braver nowadays, and I just leave my needles in and put them flat, turn them on their side. That's the main thing, to get them on their side, lying flat. If you can do it so you're not disturbing your needles, leave the needles in, and they will resolve in half a minute. They will begin to feel better very quickly as their blood pressure comes back up, and they lose this kind of pale clamminess. So that's what's happening. It's more to do with postural hypertension than needle shock. And they'll feel better, and they can lie on their side with their needles in and continue their treatment for 20 minutes. It tends to happen in the first 5 minutes of you putting the needles in, maybe sooner.
Okay, that's wonderful. Thank you. And then just a final question about the abdominal pain. As if there's a small amount of brown blood without abdominal pain, could that be an implantation bleed? Have you had much experience with how common it is that people might bleed at that point of implantation?
Yes, it could be an implantation bleed, but I mean, you're talking very, very early in pregnancy there, aren't you? I wouldn't tend to be seeing women at that stage unless I was treating them for infertility in my private clinic, but I don't do that in my hospital clinic. So yes, it may be an implantation bleed, but you're talking about in the first month, so very early on. You can get odd bits of spotting in the first 12 weeks of pregnancy, and we don't quite know why that is. The important thing is just to make sure that, as I said earlier on, that the pregnancy is still viable. And even the scan, a detailed scan, won't always show where that blood's coming from. But as long as the baby's okay, then it's fine. They just have to accept that they're spotting a bit.
Okay, we've just had a final question come in from Peter about whether there's been any diagnostic utility of examining the sacral points in the Bar-Lyell points in the sacral area.
Sorry, could you repeat that, Catherine?
Oh, it's just whether you there's apparently a diagnostic procedure using the Bar-Lyell points in the sacral area, whether that's something that you've ever had any experience with.
I tend to really stay away from the sacrum at this stage of pregnancy because I find that those lower sacral points are so powerful when it comes to induction of labour and that kind of effect on the uterus. So if somebody's got really low back pain in that area, I wouldn't needle it locally. If they've got low back pain very early in pregnancy, which they may well have if they've got a pre-existing back problem, I would tend to try and use distal points or points higher up. Bladder 23, good point for just generally tonifying the low back, or maybe points near the sacroiliac joint, but I wouldn't go lower down onto the sacrum. And even probing, using, trying to find Asher points there, I wouldn't do it. My personal choice is not to do it at this stage of the pregnancy, to be honest. Maybe I'll use gallbladder 34 if it's a gallbladder channel, or points on bladder channel if necessary. But no, I hope I've understood the question properly.
I think that's good advice. And thank you so much for joining us and for that presentation.
Bye-bye now.